My name's Rachel. I'm an occupational therapist. I've been working with people with dementia since I was about 15 or 16 years old as a diet aide in a skilled nursing facility, but I've been an occupational therapist since 2013, so a little over 11 years now, and my niche has always been dementia care. So I used to have a small patient care practice in the Philadelphia region where I worked just with people living with dementia and their care partners through Medicare Part B. And now up here in Vermont, Tamison and Abby, they do that here, which I'm so grateful for their work. But today we're going to focus on activity engagement. So how are we going to enhance activity engagement for individuals living with dementia? For any OTs in the room, some of this information might seem kind of basic. I'm happy to enhance any of this. So if you have additional questions for me, comments, anything you want to ask throughout, let's keep this casual, conversational, just chime in with thoughts, okay? Yeah, and a little bit more background about me. So this is my mum, my grandmother. So one of the picture on the left, my mum's in that picture as well, and two of her sisters. So in the middle is my great aunt Jerry, and on the right is my great aunt Doris Day. Their maiden name was all Day. So we had Norma Day, Jerry Day, and Doris Day. And that's why I named my practice Day by Day Home Therapy, kind of in their honor, because they all had dementia and all passed away with dementia. So I kind of saw firsthand the challenges that my mom went through, my aunts and uncles, as they cared for them. And one summer in between college, I was a primary care partner for my Aunt Doris. So that was a very entertaining and difficult summer, but it taught me a lot. So yeah, I also want to get to know you. I would love to know what, A, what you hope to learn today, and B, what professionals we have in the room today. So how about OTs? Any OT professionals in the room today? Okay, we've got two. Thanks, Tamison and Abby. How about physical therapy professionals? Any PTs in the room? How about mental health professionals? Do we have any? Nice. What do you do?
So I actually work for the health department now. I'm a social worker.
Oh, perfect. Love it. Social workers. Any other social workers in the room? Yay, love it. Thank you, guys. How about any family caregivers in the room? Yeah, those two. Okay, everybody else, shout out. What do you do? Chronic disease. Love it. Fantastic. Thank you.
I work for adult protective services.
Oh, fantastic. Awesome. Thank you. Love it. Thanks, Joe. Did I miss anybody else? Family doctor. Awesome. Thank you so much for being here. Great. All right. We've got a nice variety in the room. I love that. Again, if at any point you have additional questions, please just chime in. What is everyone hoping to learn today? What are you hoping to get out of today?
Tips and tools.
Tips and tools. Love it. Tips and tricks. All right. So we're going to kind of like set the stage with some background today, and then we'll get into some case examples, and I'll have you guys kind of write along with me. So as we talk about like how do we choose an appropriate activity and then how do we adapt it, you can use your own worksheet to kind of plan that out and think about maybe some of the clients that you currently work with that you can apply these tips and tricks to. All right, so our objectives today. We're hoping to, do we need subtitles? Probably not. We can. Sorry, everyone. Okay. Our learning objectives today. So by the end of today's presentation, hoping that you'll be able to identify the benefits of activity participation for individuals living with dementia, describe the methods to enhance activity participation, explain different safety considerations that go along with this, and then apply these learned techniques to your clients or patients or family members. All right, so background. Why do we talk about activity engagement? Why is this an important topic? So we know, especially from this morning, most Vermonters do wish to stay in their homes, in the community. We know that family, friends, and other unpaid caregivers are doing the majority of the hands-on care and hands-on assistance for people living with dementia. We also know that challenging behaviors, also called responsive behaviors, are reported to be the most challenging aspect of care. So when I say challenging behaviors associated with dementia, what might I be talking about? What are some examples? Aggression, resistance, refusals, agitation, repeating, maybe some like wandering or pacing, or shadowing behaviors where they follow the caregiver around. So there's so many, right? But those are just some common examples of responsive or challenging behaviors. We know that they're, again, reported to be one of the most challenging aspects of care for caregivers. We know from research that activity engagement, which is everything we'll talk about today, it's been shown to reduce challenging behaviors. So we've got lots of stats on that, which I'll give you in a minute. But when we think about approaches to care, I think it's also important for us to specify a rehab approach versus a habilitative approach to care, and then also a pharmacologic versus a non-pharmacologic approach to care. So rehab versus habilitation, usually this is something I talk about in a lot more detail when I'm talking to a room of mostly OTs and PTs, but I know my two OTs in the room know what habilitation is, so I won't spend too much time on this. But a lot of times, especially we're oftentimes called rehab professionals, OTs and PTs, but really that's putting us in this box of really only thinking about restoring or regaining function or remediating lost function. When we think about dementia care, we want to enhance their current function. We're not trying to restore lost function. And so we're really taking more of a habilitative approach, which is to say, okay, what is the person's current abilities and how do we maximize that to their best possible state? In a rehabilitative approach, we typically are just looking at the patient or the one person, so the person living with dementia, versus a habilitative approach, we're looking at that dyad, that care dyad. And when we say dyad, I think, again, this was mentioned this morning, but we're talking about both the person living with dementia and the care partner or the caregiver. So habilitative approach is the most appropriate approach in dementia care. We want to think about enhancing current function, not necessarily restoring lost function, and we want to think about the dyad, so both the person living with dementia and the caregiver. Okay, and then we also have a pharmacologic approach versus a non-pharmacologic approach. And I usually say, by no means am I against medication. We heard from Dr. Soloway this morning some really exciting advancements in the treatment for dementia. But we do also know that some pharmacologic approaches can have negative side effects. We also know that there are not currently pharmacologic approaches for many of the challenging or responsive behaviors. So it's not like somebody can come in and say, my family member is repeating questions, I need a pill for that. Or my family member's wandering from the home, I need a pill for that. Doesn't work that way, right? But what we do know is that non-pharmacologic intervention can be just as effective as pharmacologic intervention at reducing challenging behavior, and non-pharmacologic intervention doesn't have the negative side effects that can come with some meds. So again, that's why we talk about all of this. That's why we're talking about activity engagement today, because activity engagement is one of the most well-researched forms of non-pharmacologic intervention that can reduce behavior. Okay. Any questions about anything I've said so far? All right, so additional benefits of activity engagement. Meaningful and purposeful activity engagement has been shown to reduce depression. So again, that's come up a lot this morning as well, right, in a lot of our conversations. We also know, again, it can reduce challenging behaviors, which I've mentioned, and behaviors often can trigger hospitalization. So sometimes it can reduce hospitalizations, but we also know from research that not only can this reduce behaviors in a home setting, but activity engagement can also help reduce behaviors in a hospital-based setting as well. And when I say home setting, my brain's always thinking about home care, because that's what I used to do, but I'm also referring to assisted living, memory care communities, adult day programs, those types of things as well. We also know that activity engagement can help reduce care partner time spent, quote, on duty, meaning that if we can find meaningful activities that fit the person's needs, we can help set the person up with an activity, and then that caregiver can get a few minutes of respite, which can be really wonderful. And we know that Providing a sense of purpose can help increase quality of life, and that helps both the person living with dementia and the care partner. Okay, few additional benefits. So we know that significant increases in overall well-being are noted, again, for the person living with dementia, but also for the care partner. Activity engagement can absolutely help capitalize on lifelong social roles. I have lots of different examples of this coming up, but one that comes to mind, I had a friend of mine whose father had Alzheimer's. His father also was a family physician for many, many years. They ended up, for many reasons, having to move him into a memory care community. And one of the kind of behaviors, if you will, that came up is the father with Alzheimer's, who used to be a physician, was going into the records room and like pulling other residents' charts and making notes about what he thought should change. And while that was a little bit intrusive for the care team, it was really valuable for him because he felt like he was doing something really meaningful. So the OT on site was able to work with the care team and actually set up a desk in his room with a bunch of essentially fake patient charts for him to go through and still make those changes, still review things, give him a sense of purpose, and again, capitalize on that lifelong social role. So providing him with that sense of meaning. We can do that for just about everyone living with dementia. We just have to think about a variety of things in order to make those appropriate changes. We also know that activity engagement provides relaxation, social stimulation, and this point here at the bottom, I highlight this in any talk that I do. It's one of my favorite points when we talk about anything related to dementia. All humans have an innate desire to participate in our world, and that does not go away with dementia, right? It's just that the type of activity we do, that might change. The way that we're participating might change, but our desire to participate does not change. So that's what we're going to talk about. How do we make these changes so people can continue to participate? And throughout, I'll try to highlight, again, some different resources for all of you, but the picture here is of a card game, Hodie. Has anyone ever heard of that? No? So they're Vermont-based. We all love our local businesses, right? So it's two women who are local. The one woman's father, I believe, had Lewy body dementia with Lewy bodies, and they came up with this card game without rules called Hodie. So I have some examples here. I'll make sure to pass some things around. But it's really lovely, different pictures. I think they used a local Vermont photographer to take different pictures of birds. So just something where, I mean, you can make up your own rules, like let's try to match colors. You could just talk about the birds. You could just lay them out on the table. You could try to match things. Lots of different ways that you could play this game. But that's a little shout out to them. Okay, so what changes are happening to activity engagement? I use a few of these examples. These are things that my clients have told me many times over the years. Examples are things like, well, he used to wash the dishes, but he doesn't do it anymore. Well, she tells me she wants to do a puzzle, but she never actually gets it out. He used to read the newspaper, but now he just kind of glances at it and puts it down. Every time I ask her if she wants to do a craft, she just says no. Do these types of things kind of sound familiar? Some of them kind of resonate a little bit. So we're going to talk about some of why that happens, and again, how do we make these changes? So what changed? We know that the ability to initiate or start a task has changed. The task itself might be too challenging. The sequencing or following the steps can be really challenging as well. So not only is it important for us as professionals, but also for family care partners to understand how to select and how to facilitate task engagement or activity engagement. So again, not only do we need to know how to do it as professionals, but we also need to know how to articulate this to our clients. Okay, so how do we choose activities? Choosing activities. We want to, again, capitalize on lifelong social roles and interests. So I gave you the example of my friend's dad who was a physician. We have lots of examples we can pull that are similar to that. I'm really big on this second point as well, where the purpose is about engagement and enjoyment, not the end product. So for example, if we're going to use an activity like folding laundry as something we're going to work on, then our goal is that the person with dementia is participating in the activity. They're enjoying folding laundry, they're feeling purposeful, they're feeling productive. I don't care if the laundry is folded perfectly, if it's put away correctly, right? Because that's not the point here. So if it's important that the laundry is folded perfectly and put away, then we're not going to use that as our activity, right? Or we're going to get a second laundry basket with other clothes. I don't know, maybe some rags, maybe some clothes from a thrift shop that we got donated. That's going to be our activity laundry bin versus our regular laundry is something that we have in a separate area. We do want to keep safety in mind. Talk about some safety points coming up here too. And anything that's repetitive and familiar is very important, and that will make sense once I talk through cognitive levels shortly. Anytime we can try to fit the activity into a person's established routine, that's ideal. So procedural memory is a type of memory. It's kind of like our muscle memory. Procedural memory typically stays with people longer than other types of memory. So for example, short-term memory is typically something that gets impaired pretty early on in the dementia process versus procedural memory, again, typically stays with people for a long time. This is why even towards later in the dementia experience, people can still often do things like use the bathroom or brush their teeth. Eventually, again, they need assistance with that, but they can do some of those things for longer independently because it's procedural memory, it's muscle memory. So some new activities can be challenging. It's not to say we can't still embed that into procedural memory, but anytime we can keep the person's routine consistent, we can help maximize their procedural memory. Does that make sense? Any questions about that? You guys are quiet. You can jump in anytime. Sorry, it's so much of me talking. Okay, choosing activities. Again, not only do we want to think about capitalizing on lifelong social roles, but if it's possible to find an activity where it's what we call a setup activity, meaning that we can set the person up at a table and let that caregiver get a few minutes of respite where they can walk away, that would be ideal. Again, I'll talk through cognitive levels here shortly, and we'll talk about when that might be easier or harder to do. But we also want to make sure that we're considering the physical abilities of the person with dementia as well. So not just fine motor control or coordination, tremors, how is their vision, how's their hearing, what's their strength like, what's their endurance. All of these are important factors to consider when we're choosing appropriate activities. Okay, now I'm going to talk about the Allens. Other than the OTs in the room, has anyone ever heard of the Allen's cognitive model? Maybe, maybe not. Yeah, okay, no worries. It's specific to OT, so we don't hear about this talked about very often outside of occupational therapy. So I really like this model because it talks about what we call functional cognition. So I find this to be incredibly helpful when choosing activities because we can match cognitive level, functional cognitive level, to the activity, or activity to function, I should say. Okay, so I'm gonna go through this, and again, chime in if you have questions. A level 6 is what we call the planned action stage. This is all of us on a really good day. When we're not tired, when we're not stressed, we're gonna function at a level 6. It means that we have our executive functions intact. We can plan, we can sequence, we can make appropriate judgment. If you ask me to plan a dinner party, I would be able to implement the steps to be able to do that. When we get to a level 5, it's what we call exploratory actions. This is consistent with a mild cognitive impairment or mild neurocognitive disorder, if you'd rather use that term. So these individuals typically safe to live at home alone, but they need help with those really complex tasks. So things like, again, if I ask them to plan a dinner party, that would be something that they need some assistance with because of that high-level cognitive functioning. Even some things like driving, managing medications, paying bills, some of these things they might start to need some assistance with. Okay. Then we get to a level 4. So I will say most of my clients function either at a level 4 or a level 3. So I'm going to spend some time differentiating these stages. So a level 4, these are our individuals living with dementia who are goal-directed, meaning that they conceptually understand the end goal of a task. So for somebody who, if we use brushing teeth, for example, somebody who remains goal-directed, they cognitively understand that to brush their teeth means that they want all of their teeth to be clean. So they can brush the top, the bottom, the front, the back, the left, the right, and they stop the task when the task is completed once their teeth are clean. Versus a level 3, manual actions, these are clients who engage in repetitive behavior. So if we think about using that same example of brushing teeth, these are our clients who are going to probably need a little bit of assistance to get started, but once they get started, they kind of just brush, right? So they're probably hanging out on one side of their mouth for a while and need a cue to say, okay, you've got the right side, now let's move on to the left side. Or you've got the top teeth, now let's brush the bottom teeth. They might stop before their teeth are totally clean, or they might just keep brushing, again, one side over and over. So they're not goal-directed, meaning they don't understand the abstract portion of a task. They don't understand that end goal, but they can still participate in a repetitive and manual way. Does that make sense, that differentiation? I'll give you one other example too, but I'll go through the rest of these before I do that. So level 2, this is what we call postural actions. These individuals typically are very sensory oriented. So if we use that same example of brushing teeth, a lot of my clients at this stage are biting down on the toothbrush, or they're sucking the toothpaste or the water off of the toothbrush. So it's going to be really challenging for them to participate by brushing, because that's that manual action stage. They might still participate in other ways, but we as the care partner are probably doing most of the actual brushing. Again, they're probably either biting down or kind of sucking the water or toothpaste off of the toothbrush. And then level 1, this is what we call automatic actions. So this is end stage Alzheimer's or very severe dementia. Typically people at this stage are responding really to mostly painful stimuli. They could potentially sometimes respond also to different aromas or smells, different types of touch as well. Okay, so I applied this to brushing teeth, but what if we take a jigsaw puzzle, for example? So level 6 can do a jigsaw puzzle. Level 5 can do a jigsaw puzzle. They may need help if it's a very, very, very complex jigsaw puzzle, but for the most part, again, still fairly independent with most of their activities, they're gonna be good. When we get to a level 4, goal-directed. So if it's a simple jigsaw puzzle, individuals at this stage do understand that to do a jigsaw puzzle, you're going to put the pieces together to make a whole puzzle. So they're still going to participate in that traditional sense of doing a jigsaw puzzle. Versus when we get to level 3, these individuals can still participate, but it's going to look different. So they do not understand the abstract of putting all the pieces together, but they can engage in a repetitive and manual way. Meaning, let's take all the pieces out of the box. Let's flip all of the pieces over. Let's put the pieces back in the box, right? That's a repetitive and manual task that meets their cognitive level. And then when we get to level 2, again, sensory oriented. Can they hold the puzzle pieces, touch and feel them? Can we talk about the picture that we're seeing on the jigsaw puzzle? Can we reminisce about something that reminds us of? And again, level 1, this is end stage and mostly responding to painful stimuli. Okay, does that breakdown make sense? Everyone still with me? Okay. Do you see how this framework can be helpful at choosing or adapting activities? So a lot of times, again, as OTs, we can do certain assessments that help us get the objective data to know where someone falls. I should also say, outside of level 6, there's different modes within each. So there's 5-point, 5.8, 5.6, 5.4, 5.2, 5.0. So there's some minor changes within each level, but I'm just kind of summarizing for the sake of understanding them today. This can be really helpful if we observe the person living with dementia, or if we ask a lot of questions from the care partner about how someone is functioning. We can start to understand, is this person more goal-directed? Are they more manual actions? Are they more postural actions? Because as professionals, that will help us understand, how do I make recommendations about how to adapt that task to meet that person's functional cognitive level? All right. Everyone still with me? Any questions? You guys are so quiet. All right, I'll keep going. But please chime in if there's anything you want me to clarify. Okay, activity examples. So, I don't need to go through all of these. These are just some examples. Earlier today, so many of you brought up fantastic examples. We absolutely need to think about social engagement, physical engagement. I think somebody mentioned earlier, like Parks and Rec. Great place to think about how to combine a few of these. We also want to think about leisure activities, sensory activities. Sensory activities are helpful for people with dementia at any stage, but especially helpful for those at that level 2 postural action stage. Okay. And I'm going to give you lots of examples here coming up too. Okay, so other things to consider, things like volunteering. These are just some of the things I know my friends have volunteered for in Vermont. Can we think about interviews? So connecting with local students. I've had clients before where we think about, the person living with dementia used to always be a mentor. They used to always be a teacher. How do we capitalize on that? How do we allow them to still feel as though they're contributing? So sometimes we'll find local students in the area. I'm thinking mostly about my time in Philadelphia, but we could kind of take a student and think about pairing them with someone with dementia, and they could do either hours of volunteer work, the student, or possibly class credit, and then they could kind of interview the person living with dementia, which allowed the person with dementia to feel as though they were contributing. So it was really a win-win. We can also use this to our advantage when we think about resistance to care as well, which I can talk about later too. Some other things to consider, sometimes local medical universities will recruit volunteers from the community. Again, a lot of my experience comes from Philly, so I think about the school that I went to, there was something called Health Mentors, so they would pull people in from the community, assign them a team of students, so a different student from each healthcare profession, and they would work together to figure out how would we support this client, so that could be another great way of getting involved as well. There are also great library groups, lecture series, museums, orchestras, concerts, comedians, Arts Philly, which I'll talk about, watching different activities. So around here, there's so many great things to just observe. So again, especially for people at that level 2 stage, just watching, being outside, feeling the air on your face, great sensory experience, and very fitting to functional cognition. So you can watch kite surfing, you can watch a local sporting event, sit on a bench outside of a dog park, take a nature walk. All of those are great. Arts Philly is one of my favorite nonprofits. Again, they're based in Philly, but they do have a lot of great virtual programming. The nonprofit specifically developed for people living with dementia and their care partners. So it's all different arts programming, free to the consumer, and again, adapted for people living with dementia. So sometimes they'll do museum tours, sometimes they'll just pull different artwork up on the screen and I'll talk about it, or they can listen, that's fine too. They'll also sometimes do, at least during early days of the pandemic, people could sign up and all get sent a craft kit together, and then they would virtually kind of all walk through the steps of that craft and kind of all participate together too. So another possibility for you. And now I'm just going to share some examples of some of my clients. If you see any of my clients' faces, they've given me permission to share them with you. Okay, so on the left here, this is what's called a twiddle muff. So this is a client who, she was functioning around an Allen's level 2. So again, postural actions, very sensory oriented. She was also doing a lot of scratching on her skin. So we knew that she needed some sort of tactile activity to try to distract her from the scratching. So it's a muff, for your hands, but it has lots of different, again, sensory activities on it. So there's snaps, different things to feel. It's called a twiddle muff. Yeah, twiddle muff. It's got a fun name. Oh, thank you. Busy blankets, love that. It's also fidget mats, fidget aprons. Lots of fun things that can, again, meet that level 2 postural action, sensory-oriented stage. And if I didn't touch on this too much when I talked about the Allens, but as we progress through the Allen stages, attention span also gets significantly shorter. So by the time we're at the sensory-oriented stage, attention span is typically a maximum of a couple minutes. And that's if everything's going really well. Meaning that she's going to have this on her lap and engage with it for a few minutes, and that's great. And then she'll probably get distracted by something else or kind of push it away. And then we can put it back in her lap, and then she can engage for another few minutes. But we wouldn't expect her to engage with this without a cue or some sort of support to keep her engaged without doing that kind of every few minutes. Does that make sense? Okay. On the right, this is a client of mine who used to do a ton of beautiful artwork. This is a husband who said to me, I ask her all the time if she wants to do her art, and she says yes, but then she never does it. So a lot of this was education to him about, she's having trouble initiating. So we're not going to expect that if she says yes, she wants to do the activity, that she has the capacity to then gather up all of the materials and set herself up with it. So instead, I just asked him, can you bring all of the materials that you think she might use to the clinic, and let's just see. So I just kind of set her up with the art supplies. I started painting alongside her. Clearly, I'm very artistic with my green blob at the bottom, but just painting next to her, right? Engaging in a repetitive way. And when she had access to the materials, she then was able to engage. She was able to engage, I think, 45 minutes uninterrupted. So she's probably closer to that high 3, low 4 cognitive level. Her husband also needed some education about, her artwork isn't going to look the same as it did when she used to paint before dementia, right? So her kind of abstract squiggles, that's great. She's happy, she's participating, it's meaningful for her. He just needed to remember that it's okay, that this is not going to look like her masterpieces before. Okay. Some more examples. So this picture on the left just helps remind me of this is my client. He had Parkinson's and Parkinson's dementia. So he was doing a lot of rummaging in the house. So moving items from one room to another. A lot of times they were like important bills and things that were not great to have misplaced. Other things that he was rummaging quite often were related to his favorite pastime of fly fishing. So rummaging is actually one of the better behaviors to have. I don't know if that's the right way of saying that, but rummaging is actually a really meaningful activity in and of itself. We just have to figure out how do we provide a little structure to it so that it's not negatively impacting the care partner. So we took his enjoyment in rummaging and his enjoyment in fly fishing. So this here was kind of like a binder almost he had with different pockets in it of all different fly fishing material. So feathers, all sorts of, like sparkly type things. He taught me a lot about fly fishing that I did not know beforehand. But we ended up creating essentially like a big rummage box of fly fishing materials. So this was in there. We got a clear, I guess you'd call it a tackle box, clear tackle box-like item, and kind of glued that shut so he couldn't hurt himself on the sharp hooks, but then he could still look at all of the really colorful flies that he had made. We put a reel in there. He had different books on fly fishing that were really colorful, had colorful fish in it, so he could kind of piece through and talk about This is a really great activity to do with a caregiver, especially if you have like a paid caregiver in the house who's like, I don't know how to engage them. Go through a rummage box, talk about it, talk about how the items feel, talk about what you're looking at, reminisce about stories related to fly fishing. Again, I had him teach me all about fly fishing. That's a great activity that gives someone a sense of purpose and control. So yeah, rummage boxes are a possibility. They don't have to be a themed rummage box, but a rummage box is certainly an option. The picture on the right, this was a gentleman who clearly valued organization and liked his tools. So I knew he was functioning around an Allen's level 3, so repetitive manual actions, and the wife was like, I have no idea how to engage him. I just don't know what he would do, because he used to like to fix appliances and tinker, and that's just becoming more challenging because he's not goal-directed anymore. So instead, we could take things and say, okay, he clearly likes organization. He appreciates items related to tools. So I showed up one day and just said, these nuts and bolts got so mixed up while I was driving here in my trunk. Could you help me sort them? So nuts in this jar, bolts in this jar. So he was thrilled again to be able to be helpful and do something repetitive in nature, because that's meeting his cognitive level 3. Other things that we can do, again, we have to keep safety in mind, but for people who like to tinker, sometimes you could just go to the junkyard. Around here it's CSWD. They have like lots of carts where people will drop their broken electronics. If people like to tinker with electronics, just pick up one from the dump. I have one client who would just use a screwdriver and like pull all the pieces out, and that made him feel useful, productive. He didn't necessarily put it back together, but that's okay. That could be another activity for you to consider as well. Okay. We have on the left, this is my client who, this would be a fidget mat or a fidget lap pad, a twiddle mat. This individual, she had Parkinson's, significant fall risk, so she was getting up and just rummaging throughout the house. The husband was like, I don't know how to keep her seated. Again, more limited attention span, but the fidget mat was able to meet her at her cognitive level of a level 2 postural actions and keep her engaged for longer stretches while she was seated and prevented her from getting up and having falls. On the right, this individual is a little unique. She had progressive supranuclear palsy and dementia associated with that, but the daughter kept saying, my mom loves to garden, but it's just way too much for her to actually get into the garden and bend down and get her hands dirty. That's an easy one. We'll just bring the gardening to her, right? So brought her out on the porch, set up a table, got some tomato plants, some soil. We can certainly do gardening from tabletop. We don't have to actually physically bend down and get in there. So again, some adaptations we can make considering someone's physical needs. Okay. Any questions about anything? Anyone want to chime in? Thoughts? No. Am I boring all of you? Okay, safety. So again, I just mentioned falls. Activity engagement in and of itself can help reduce falls, but we also want to consider the activities we're choosing, and if we're matching them to someone's abilities, we don't want to increase fall risk. So I had one client one time who used to do a lot of window washing, and he really loved doing that. So instead of necessarily setting him up at a window to wash it from standing, we could bring a chair over to the window and set him up to do some window washing from a seated position, right? So again, just making those changes to reduce safety risks. We also want to consider assistive devices in dementia. Again, I know there aren't any PTs in the room today, so I don't have to get on too much of a soapbox, but providing someone with dementia an assistive device, especially if they have moderate or severe dementia and they've never used a walker before or a cane, it can actually increase their risk of falls. And that's something that can be really challenging for families, because if there are PTs telling them, you have to get mom to use her walker. And then they're kind of hounding on their mom, like, Mom, you forgot your walker again. You've got to use your walker. Then that can create agitation. And now we have an increased risk for falls because they don't know how to safely use the walker. It can just be a big mess of a situation. So we want to make sure that we're only making recommendations for assistive devices when it's appropriate. This can be really tricky because PTs will often say to me, okay, well, if they have advanced dementia and they're a fall risk, what are we supposed to recommend if not a walker? We can still talk about how do we safely get them standing, maybe holding grab bars or something if they're doing something stationary. We can sometimes do rails in the house. Yeah, go ahead.
I worked at a Durham medical equipment store.
Okay, awesome.
One of the things that we tried to educate people that came in, because there was a feeling of guilt that their parents are getting worse, they want to do the best for them.
Yes.
And the best sounds like the most expensive. So they
Yeah.
want to buy these $400 nitro with all the bells and whistles,
Yep.
rolling walkers. And the problem is whenever you have a walker with a seat and handlebars, which people can't grip in the first place, you set up they don't remember to put on the brakes.
Yes.
So you're better off with what's in that picture.
Yeah, a
Because
standard
They
walker.
know they can't sit if there's nothing underneath them usually.
Mm-hmm.
And there's less apt to fall.
Yeah, I appreciate that. So the comment for anyone who's watching the recording, in case you didn't hear, was about thinking about the most expensive does not always equal the best fit. Thinking about a walker where you have to grip to stop it, that can be challenging because it's one more task and something that someone with dementia has to remember, which is not very likely. And a seat implies sitting. So much, especially at that level 3, people are focusing on what they can see, what's directly within their visual field, and they're interacting with things based on what they look like. So if they see a chair, they're more likely to sit in it. If they see a door, they're more likely to walk through it. So if they don't have that seat available to them, they're less likely to try to sit in it and potentially can reduce falls. So thank you for that comment. Yeah, a standard walker or a standard rolling walker would actually be one of the safest of all of the options available. Again, there's unique situations for each person, but sometimes even just hand in hand. You know, we don't always think about that as being the safest, but just walking with somebody by holding their hands sometimes can be the safest option. So we definitely want professionals who kind of have that dementia lens, who can provide the most realistic assistive device or recommendation about how to ambulate. Any other comments or questions about that? I know we could probably go on a whole day-long discussion about walkers and canes and dementia. I certainly have had those clients where, you know, somebody before me came in and told them to use a walker, and then I have the client carrying the walker around. Have you ever had those clients? Or like using it backwards? Again, increasing risk of falls.
The other piece of that is I just show up to a patient's house and they're like, oh, my private caregiver brought me this rolling.
Yes.
But if the pace at which they normally walk is extremely slow, that's not actually an appropriate device for them because they're going to push it and lose it and then fall forward because their hands were occupied with something else.
Great point, Abby. Thank you. So that's it. We have so many well-meaning individuals, right, who are picking things up where they find them, or, oh, I had this in my basement from when my grandmother used it, and I figured I would give it to you so you don't have to buy a new one. So lovely, but if it's a rollator, rollators move really fast. Not typically a great fit for somebody who is walking a little slower because they can get away from them and then, again, can end up having a fall. Thanks for sharing that, Abby. Yeah, we also know, I won't try to quote the exact statistic with the percentage, but you know, if all of you or I try to use a walker, we're trying to dual task or multitask, we're only using a small percentage of our brain power to do that, right? We don't have to focus all of our attention on using the walker. We can use the walker, we can walk safely, and we can possibly have a conversation with somebody around us. When someone with dementia is walking and using a walker, they're using substantially more brain power, more energy on the walker meaning they're not concentrating as much on the walking. That's why they're at an increased risk of falls. I think I want to say I'm going to not get the stats exactly right, but for us, it might be closer to 10%. For someone with dementia, it's over 30%. That's a pretty significant jump. So yeah, something to consider. Okay, we also want to think about modifying the environment. So safety isn't just about falls. It's also things like using a stove safely, driving's a big one, wandering from the home, impulsivity. Impulsivity can happen with people with any type of dementia, but most of the time where I'm dealing with really scary impulsive behaviors have been individuals diagnosed with frontotemporal dementia. That's when we can start to see a lot of things like, gambling, or maybe, still using the internet, but maybe not safely. So giving money away to scams, or doing a lot of online shopping, spending lots of money that way, that type of thing. Again, I mentioned this a lot, but we want to consider the functional cognitive level. So really thinking about where they're functioning and matching our activity to how they're doing. I did mention this briefly, but again, level 3, anyone with dementia, but especially at that level 3, people are going to interact with what's within their visual field. And again, if they're not goal-directed, that's level 4. They're at a level 3, repetitive manual actions. They're not thinking abstractly, so they're not thinking about what's outside of their line of sight. That certainly impacts how someone engages in a task, right? If the items aren't set up right in front of them, they're likely not going to engage in the task. So we want to be really thoughtful about that. Okay. Any other comments, questions about safety and activity engagement? Yeah, please.
Just chat a little bit about modifying the environment regarding driving.
Absolutely,
Just
yeah.
Don't have to go.
No, I appreciate it. Okay, so if we think about modifying the environment related to driving, so again, this is going to depend on the person's functional cognitive level and what the actual manifestation of the challenge or behavior is. But for some people, the issue is that they're either talking about driving, actually getting in the car and trying to drive. So we have a few things that we can do. One of the easiest is hiding the keys, modifying the environment, maybe placing them out of sight. So again, if it's not in line of sight, it's going to be less likely that someone's going to engage. That goes for not just the keys, but the car itself as well. So let's say the car typically gets parked in the driveway and the person can see the car every day. They're going to be thinking about driving because it's within their visual field. If we could park the car outside of line of sight, so maybe it's in a garage, maybe it's around the corner at a neighbor's house, around the block, somewhere that's not directly in line of sight, can help reduce, I'm not going to say it fixes all of the issues around driving, but can help reduce how often someone's talking about or trying to drive. Does that answer your question?
Yeah, that's good. I mean, what about, like, there's somebody still driving, maybe they're earlier.
Yeah.
I mean, that whole thing about, taking that away.
Yeah, that's a great point. So that can be tricky as well. So few things to consider there. Driving's a really difficult one because so often I hear families say, oh, well, they're still driving safely. We only have them go to local places. They only go a few miles away when they're driving. That sounds great because it sounds like we're tapping into procedural memory, right? Muscle memory, they're only going to routine, familiar places. The challenge is, as soon as we have something that breaks procedural memory, something unfamiliar, then everything doesn't apply anymore, right? So if we have construction, if there's a car accident, if there's a detour, anything out of the ordinary happens, that person can no longer rely on their muscle memory and has to tap into other kinds of memory that are more impacted by dementia. So I'm a big proponent of really stopping driving very early on in disease progression. I know that's extremely challenging, again, for a variety of reasons, because we're taking away someone's independence, and that's a huge part of what we're talking about with activity engagement is how do we allow someone to continue to feel valued, meaningful, independent Driving is one where I try not to take many risks. So there are certainly like driver rehab specialists. Some of them are other occupational therapists who can do more detailed cognitive assessments and really figure out, where's the line of, is this person safe to drive? Are they not? I usually err on the side of caution. And as soon as we're talking about dementia, I try to start to talk to my clients about what's our plan, right? Is it that the spouse or care partner is going to be doing the driving? Are we thinking about public transportation? What does that look like? Is that going to be overwhelming, overstimulating? Can we do ride share options? How are we still going to get to where we need to go once this person stops driving? But yeah, you're absolutely right. It's something that's concerning very early on, and maybe somebody is still more aware, and so something like placing the car in the drive or in the garage or around the corner isn't enough. They're still going to want to drive or ask to drive. In those circumstances, we have a few options. Sometimes we do have to be really firm with people. This is one of the few times where I'm more direct with someone with dementia and telling them, your doctor has established you're no longer safe to drive. Sometimes I ask the doctor to actually print it out so we can refer to it. It's also taking the blame off of the care partner. We want the care partner, the family member, to always be on the same team as the person with dementia. So I never want to pit the person with dementia against their spouse or care partner. I want them to feel like they're on the same team so we can reduce agitation, resistance, behavior. So I usually say, my little catchphrase is acknowledge, reassure, redirect. So acknowledge what the person is saying or their emotion behind it. Reassure them, again, you're on their team, you're sticking with them, they're safe with you, and then redirect into another activity or conversation. So acknowledging would be, I know you want to drive. This really sucks that the doctor said you're not supposed to drive. I'm going to try to figure this out with you, or I'll give you a ride later today. We'll figure out how to pick up what you need. Right now, though, I could really use your help with this load of dishes. Can you help me put these away? So acknowledge the emotional state, reassure them you're on their team, and then redirect. A lot of times I'll redirect by asking for help with something, or sometimes reminiscing, that type of thing. Any other comments or questions about that?
I was just thinking too, Rachel, maybe in the early stages, if, say, the spouse or the caregiver is driving, having the person with early dementia be in the passenger seat and engaging them more. So where should we go now? Or prompting the activity with, would you like to go for a ride today? Where should we go? So keeping them involved in the driving task, but as a person.
I think that's fantastic. Yeah. And I'm going to totally go on a tangent here for a second, but I think what Tamison said is so important because it gets at the underlying reason for the agitation, upset, resistance, anything related to the driving, which I think in this case is a loss of sense of control. But what you're doing is still giving them that sense of control. So you're meeting that underlying kind of trigger. So a lot of times when we think about a behavior, I know I'm totally on a tangent right now, but if we think about a behavior, we have kind of three categories of things that we look at. So if the behavior is, repetitively asking to drive, then we look at what's happening within that person with dementia that's triggering that repetitive behavior. In this case, sense of loss of control, it's a really big factor. Or anxiety about driving could be triggering that repetitive questioning. We look at the caregiver, what are they doing and saying that could be contributing to that behavior, and then again, the environment. So is there something in their visual field that's contributing? Is it the social environment, physical environment that could be triggering the behavior? And then once we figure out the trigger, that's when we kind of backtrack to figure out how can we then establish a strategy. So thank you, Tamsin. That's a beautiful connection too. If sense of loss of control is a trigger, then providing them with a sense of control of where should we go next? Do you want to go for a drive? Those are ways of still maintaining control. We can use that in a variety of ways with activity engagement of all kinds. One of my clients, a few slides, just this one. This client, so we were having trouble, even though she was doing a lot of rummaging and kind of some pacing in the home, we were still having a really hard time getting her into the bathroom to use the toilet. So we tapped into her background of, she was an interior designer, and we knew, again, sense of loss of control was a factor for the resistance to going into the bathroom. So the strategy we used was the husband would say, you know, hun, I was thinking about repainting the bathroom. I would love your opinion on what color to paint the bathroom. Come with me. Or I bought some new hand towels to put in the bathroom. Will you come take a look and let me know which one you like better? So again, capitalizing on her lifelong social roles and interests. She loves interior design. Thinking about how do we give her a sense of control. So what's your opinion on color? What's your opinion on towels? And then just casually, take a walk with me. Once she's in the bathroom, again, what's within visual field is going to enhance engagement. So when she's in the bathroom, sees the toilet, it's going to be a lot easier to get her to engage in using the toilet. Any other questions, comments? All right, I'm going to talk a bit about adapting. So we've talked about choosing activities, what are some examples, but now what do? How do we actually adapt these activities to maximize engagement? So we're going to talk about how to simplify the activity or task, simplifying the environment, and maximizing communication. So simplifying the activity, again, this is a really basic example, but we have here washing dishes. So if we think about reducing the complexity of the task, so if we have the example of washing dishes, maybe washing all of the dishes is too complex of a task. So instead, let's break it down. Maybe we're only washing plates and only silverware instead of glasses and bottles, which are maybe a little bit more challenging to wash. We could also think about reducing the number of steps. So we think about setting up washing dishes. We're turning the water on, we're washing, we're rinsing, we're drying, then we're putting it away. It's a lot of steps. So instead, maybe you as the caregiver, or professional, maybe you're washing and rinsing, and they're the ones who are drying. And maybe together you're putting them away. Or maybe they're washing, and you're rinsing and drying and putting them away. Right? So really just breaking down what could be a complex task into simple steps and having them just participate in one or two of the steps. We could also change the objects themselves, so the size of the objects, the material, the weight, the color. So for example, if the sink is white, we don't want all white plates, because that's going to be really hard to see. So instead, we're going to think about, can we get brightly colored plates for them to wash? Maybe lifting a ceramic plate is too difficult because, they have weak hand strength. Okay, can we think about plastic plates instead, or something lighter weight? Again, I already mentioned this before, but I'll talk about this over and over. We want to change the purpose from the end product to the process. So the purpose is enjoyment. It's not about, are the dishes clean? And if it's really important that the dishes are getting super clean for that particular day, time, then we're not going to use that as our form of activity engagement for the person with dementia. Sometimes, though, I've had clients in the past where washing dishes was something that was kind of their day-to-day task that they like to do. And the caregiver would say to me, like, oh my gosh, now it's like double the work for me. Because now I have to go through the cabinets and find the dirty plates and pull them back out and rewash them. So a lot of times what we would do is put just one of those like big plastic bins right next to the sink. And then that way when they washed and dried, they could put them in the bin. And then the caregiver knew, okay, this is the set that I'm rewashing before I put them away. And then set up and start the activity for your family member, your client. So I vividly remember one client, this isn't even one of the reasons I was there, the caregiver just said in passing, it's driving me crazy that my husband is washing the dishes with his hands. Like I just keep saying, please use a sponge, but he just keeps washing it with his hands. So I went over to the sink, I put some soap on the sponge, I didn't say anything, I just handed him the sponge, and he started to wash all the dishes with the sponge. So sometimes it's as simple as starting or initiating the task with the appropriate objects. It does not always require verbal cues. Again, it could have been that the sponge, I don't remember exactly, but it could have been that the sponge was under the sink or in a drawer or behind the faucet. If it's outside a visual field, it's going to be really hard for him to use that object. So instead, just handing it to him can increase engagement. All right, so we're going to think about this as it relates to a jigsaw puzzle. So how would we reduce the complexity of a jigsaw puzzle? You can just shout it out. Larger puzzle pieces. Thank you, Tim said yes. So reducing the complexity of a puzzle using larger puzzle pieces. Great. Reducing the number of steps. What's an example? Perfect. Yes, we already have the pieces out of the box. Beautiful. So that would be one way of reducing the number of steps. Changing the object size, material, weight, color. Again, that could be having larger puzzle pieces. What else could we possibly do? Smaller puzzle. Great. Simpler pictures. Great. Great examples. Change the purpose from the end product to enjoyment. That would just be, we're enjoying the puzzle. We don't care if the puzzle pieces are all put together at the end. We don't care if they're put together correctly. It's just the process. And then set up and start the activity for the person. So again, that would be taking the box out of the cabinet, starting to get the pieces out, inviting them to join you. All right. Again, some of this might be kind of simplistic, but just to really reiterate our points here. So of A, B, and C, which of these would you say is the most complex jigsaw puzzle? C, correct, yeah. And why is that? Smaller pieces, very dark, yeah. Exactly, yes, low contrast, smaller pieces, more of them, right? And so the least complex would be A. Great, so higher color contrast, bigger pieces, fewer of them. So again, when someone says, oh, my family member can't do fill in the blank, a puzzle, for example, I usually ask, well, what does that task look like, right? How are we setting them up with it? In this case, I think everyone can do a jigsaw puzzle. It's just, how are we framing it? Are they holding the pieces? Are we talking about the puzzle? Are they actually putting it together? All of that's still meaningful engagement. We just have to reframe it in our minds. And again, I have lots of examples I can share with you. Puzzle A is from a company called Mind Start. I have some examples of their products on the table up here that I'll pass around. But they develop activities specifically for people living with dementia. I really like them because I don't feel like the pictures are necessarily particularly childish, but they're still really large pieces, high color contrast. They have more than just puzzles too. They have some lace cards, they have some crossword or word searches, that type of thing. All right, great. Simplifying the environment. So when we think about reducing clutter or visual distraction, so in this case, I'm using the example of making a sandwich. So how would we reduce clutter and visual distraction? So removing all unnecessary items from the counter. Consider using a plain colored tablecloth, not something that's like patterned, checkered. I'm going to go on another tangent. It makes me think of, I used to monitor some big Facebook groups for caregivers of people living with dementia. And I vividly remember one post of a woman who, I think she took a video of her mom, and the caption was something sad, something like, mom doesn't know how to eat anymore, or something like that. And I watched the video, and her mom was sitting at a table. She was working on a coloring activity, and then her daughter came and handed her a cookie, and the mom started coloring on the cookie. And it seems like, oh man, mom can't eat anymore. But if we think about it, the environment just wasn't set up for that task, right? If we had taken the crayons away, taken the paper away, and we set the environment up to look like it's time to eat, so we put out a cup of water, a napkin, a plate, and then hand her a cookie, and we start eating a cookie next to her, chances are she's going to take a bite of the cookie, right? So thinking about the impact of environment can be really substantial. So back to making a sandwich, we can also think about not just reducing visual distraction. So in that example, it would be removing the art supplies. Here, it would be removing anything unrelated to making the sandwich. We also want to reduce noise. So turning off the television, turning off the radio. And when I say off, not just mute, because it can still be a visual distraction if the TV's on. I have a client right now who she'll take phone calls, and the paid caregiver will just put the TV on mute, and all of a sudden she'll be on the phone with her daughter and will just start reading headlines of things she's seeing on the news. And the daughter was really confused, like, where is all of this coming from? She was talking about like some traumatic events, like a bank robbery, and then she figured out, oh, the TV's still on, it's just muted, so she's picking up on that. So turning the TV completely off so it's not a visual or auditory distraction can be helpful. We also want to make sure we're providing adequate lighting. Adequate lighting doesn't just mean enough lighting, it also means reducing glare. Sometimes bright but still warm light can be the most helpful. We also want to remove dangerous items, so removing sharp knives from visual field for something like making a sandwich. For other activities, it's, again, removing any dangerous items from visual field. I had a client one time who was using toilet bowl cleaner as shampoo. It was something as simple as the son was storing it in the shower stall. So she was in the shower and just engaging with what was within her visual field, right? So when we remove those items from visual field, we're going to reduce the likelihood that they'll engage with it. Providing only the items needed for a task. So for making a sandwich, we only want to have the bread or the wrap and the items that we're going to put in the sandwich. We don't want to have, again, all of this other visual distraction. And then providing items within visual field. Sorry, I keep repeating myself. Some of these points are important, but we want to make sure all of the items needed for making a sandwich are directly within their line of sight. Usually, it varies from cognitive level to different cognitive levels, but usually we say 24 inches is usually the visual field that we're aiming for. So about 2 feet. Okay. So if we apply this coloring, again, reducing clutter, visual distraction, it would be removing anything in the item not related to a coloring activity. Reducing noise, that would be having side conversations somewhere outside of earshot, turning the TV or radio off. We want to make sure there's not glare so they can still see what they are engaging in art-wise and what they're coloring, providing only the items needed for that particular task. So again, just crayons or art supplies and paper, and then providing it within their visual field, so within a few feet. Okay, so again, kind of simple, but if we think about these pictures, what would you say is if we're gonna just have a meal at a dining room table? What's the B? Yeah, I would agree. That would be the ideal place. Oh, you're good. I say B because I don't really mind C either. It's just the glare. The glare is pretty rough in C, right? But B, we've got a nice plain colored tablecloth. Having like a bright colorful plate on top of that tablecloth is going to make it easier. And A is cluttered and confusing. If I sat down at that table, I think I'd be distracted and start, I don't know, painting, reading the newspaper, but probably not eating. Okay. Any questions about this or comments? Go ahead.
Can I just say something about context too?
Yeah, please.
Because I've been in situations in the past where caregivers are bringing like mom out to the kitchen sink to help her brush her teeth because there's more space there, right? Mm-hmm. And they give it to her and she's like frozen. Yeah. Because that's not where this activity happens. Yes. So her brain is like, I don't know what I'm supposed to do here. And she, like many other women, have probably used a toothbrush to clean some small spaces at some point in her life. And so and then daughter is frustrated because she's rubbing the toothpaste on the kitchen sink. So just thinking about where you're trying to initiate an activity is also really important.
Yes, thank you. Great point. So thinking about the context, where are you initiating that activity? Just repeating it for anyone who's watching the recording. So Abby has a client who the daughter will kind of bring her mom out to the kitchen sink to do toothbrushing because there's more space, probably thinks like, okay, well, instead of being in the cramped bathroom, let's come out and have more space here. But it's the kitchen, and so she starts using the toothbrush to kind of clean around the faucet. Absolutely makes sense. Yeah, I think sometimes that happens too when we think about toileting. A lot of times we'll see like bedside commodes used in a bedroom. It's not to say I'm against a bedside commode. Sometimes we need to consider that and use that, but context is challenging, right? If we all of a sudden are asking someone to toilet in the middle of their bedroom, that context doesn't always make sense. So that can be a hard thing to start for someone with more advanced dementia. Yeah, thank you so much for bringing that up, Abby. Great point. Anybody else want to chime in? Any thoughts? Okay. All right, these are, again, some OT concepts. So the idea of downgrading, we're really trying to find what we call an OT, the just right fit. So yes, we want things that the person can do, but we don't want it to be so easy that it's really boring to the person, right? So we can, but again, we can take activities that someone enjoys and we can downgrade, make different aspects of it easier to meet them at their cognitive level. So this is just a picture of my sisters and I doing a jigsaw puzzle. We really like puzzles, but this would be a pretty complex task. Again, I'm using puzzles as an example in many slides here, but how would we adapt this to make it easier? So you guys have already given me some great feedback. We would have a puzzle that's smaller, less pieces, larger pieces. You've picked up on the fact that one of those slides had a glare, so we would want to think about, having possibly a tablecloth, removing the glare. There's like a little remote over here. We were listening to some loud music in the background, so maybe turning that off. There's also the social context, right? There's 3 of us doing a puzzle here, and while that's great for socialization, it might be confusing for the actual task or too overwhelming, so maybe we just want 2 of us doing the task instead of 3 of us. So there's lots of different ways we can adapt and downgrade. Okay. These are not my clients, I wish they were, but these are just some pictures to kind of cue me to talk about the importance of socialization as well. I won't harp on that too much because I do think this morning did a great job of talking about how important social connection is. Oftentimes, and I think Rhonda and I were talking about this over the break, oftentimes as people progress through dementia, not always family, but especially friends, they get confused about how am I supposed to show up and continue to interact with the person, especially if the person with dementia starts to have aphasia, difficulty communicating, difficulty talking. Friends don't always know how to engage. So a lot of times what I'll recommend for family members is to kind of be a little bit more specific about your ask. So sometimes I'll say, could you ask your friend, hey, can you pick up lunch from this restaurant and come over and enjoy lunch outside with mom on Thursday? So being more specific about what it is that you're asking them to do. You can also give them tips and tricks for how to communicate with the person. So reminiscing is a really great fallback activity. It's something that's tons of research on how important and meaningful reminiscing can be. I'll usually tell people, come up with a story from when you were younger, from when you first met. It could be from childhood. And just start to talk about it in detail. I was thinking about you the other day. I went to this dance, and it reminded me of one time when we were younger, and we went to this dance and listened to this music. You can still tell a story with vivid detail. It doesn't mean that the person with dementia necessarily has to communicate back, but they can still participate in a way that's more comfortable for them as they're able. Does that make sense? Yeah. Reminiscing is also a really great tool for redirection. When I talked about that acknowledge, reassure, redirect can be really meaningful when we use reminiscing. Blueberry picking. This was, again, I was thinking about different unique activities specific to Vermont. Blueberry picking, I've done a lot more blueberry picking in Vermont in the last year than I have done the rest of my life combined. So there are lots of great activities where we don't necessarily have to talk to one another or have a reciprocal conversation, but we can still engage in a meaningful activity together. This is still meaningful social connection where we can go and do an activity side by side. Again, this is great for multiple cognitive levels because it can be something that meets somebody at a goal-directed stage. It can also be a great repetitive manual actions activity, right? You keep picking blueberries. It can also be a great sensory-oriented activity for someone at that postural action stage. Popping the blueberry in and tasting it, that's a great sensory activity. So things like this can meet people at any stage. Okay, and then communicating effectively. So a lot of these are techniques and strategies that many of you probably already know, so I'm going to go through these pretty quickly. We want to use statements instead of abstract questions. So I usually say, we don't want to ask something like, what do you want to eat today? It's a really hard question to answer, right? What do you want to eat today? That means that I have to think about, okay, what time of day is it? What meal is appropriate at that time of day? What foods are appropriate at that meal? Which of those do I like and which of those do I want right now? That's a lot. I don't know about all of you, but I can't often answer that question. So instead, we're going to use statements instead. So, or if we do offer choices, no more than 2 at a time. And if we can offer a visual choice, that's even better. So do you want the salad or soup? And actually being able to show them a salad versus soup is going to be more helpful, make it easier for them to make that decision. Or we could even just get some soup on the table and put it in front of them, and we start eating our soup next to them, and chances that they'll start engaging in eating soup is higher, right? That's particularly helpful for people who may often say no to activities like eating, but we know that they are actually hungry. Okay, acknowledging what our client is saying. So I think Dr. Salloway made a mention to this morning, where he said, go along with their belief of what's true. Right? We don't want to rationalize with the person. We don't want to try to orient them or reason them out of their reality. We just want to meet them in their reality. Again, if we can acknowledge, reassure, redirect. We can acknowledge either what they're saying or the emotion behind what they're saying, reassure them that we're on their team, and then redirect them. Okay. Any questions about that?
Goes back, I think, a little bit to when you're talking about simplifying. When you're interacting with people and maybe giving care, how do you address making things simple versus treating the person like a child?
Great question. So the question is about how do you simplify versus treating someone like a child? That is such a great question. I think a lot of that does come back to communication style. So I think the way that we're framing something has a lot to say about the task at hand. So for example, the client that I had mentioned where I said, oh man, these nuts and bolts got really mixed up in my trunk. Will you help me sort them? If I had just come in and said, sort these nuts and bolts, that might have felt a little too childish, like too simple. But instead I'm framing it as like, this would be a huge favor to me. Will you give me a hand with this? That reframe can help, again, allow for a sense of control, to Tamison's comment earlier, which can help it not feel so childish in nature because we're asking for their input and help. Does that make sense? Yeah. Does anyone else have any comments or thoughts, suggestions on that? Yeah, I also think, again, when we think about the materials themselves, sometimes, again, if we think about, I keep using puzzles because I love puzzles, but if we think about a puzzle, if I think about finding a simple puzzle at a store, if I go to like a dollar store, Five Below, a lot of the really simple puzzles are childish in nature. Like the pictures themselves are cartoons or Disney, or that's why I end up buying from companies that are specifically designed for people with dementia, because then I know that the content or the context is maybe a little bit more mature, even if they're still highlighting bright color contrast. It's not like a cartoon feature. Yeah. Great question, though. I appreciate that. Any other thoughts, questions? Yeah, please.
One of the things I've noticed in helping my friend with her parents who have had dementia is that when they began to exhibit it, she sold their apartments in New York City and brought them to Vermont, 30 miles from where she lives. Mm-hmm. It was a huge change for them. It was an entire disruption of their social network, their religious support, and she was young. She was only like 37. She didn't understand it. She was in the middle of really establishing a professional identity for herself and didn't want to be a caregiver at all. Mm-hmm. Mm-hmm. Would get angry, would get frustrated with her mom. We're doing better with her dad, who's still living. Her mom is not. But she was always more of a daddy's girl anyways. But what I've said to her is keep as many routines as you can.
Yeah.
You didn't find anything to substitute for your mom because she didn't have a lot of pastimes. Her friends and her church were her hobbies. And that was gone. So maybe had we established a routine of taking her to church every Sunday, she might have met people and, it's kind of hindsight 2020. I said, but you have an opportunities with your dad. He loves sports. He loves the Red Sox. He loves just going and being a participant, watching.
Yes.
I said, so as many of those things that you can build into a routine. He likes his walks in the morning. I said, what I would do is tell him not during rush hour.
Yes.
So,
Perfect.
Those kinds of things go a long way.
Absolutely. And I think you hit the nail on the head in so many different aspects, not only thinking about capitalizing, again, on lifelong social roles and interests, but also highlighting the importance of routine. Routine is important for people with dementia at any stage. Oftentimes, if I'm lucky enough to get to work with somebody has mild dementia or is newly diagnosed, that's one of the most important things I'll highlight. As many things as we can embed into a routine as possible will enhance procedural memory.
And so we would be her support system. When she had to go out of town, we would check in on her dad, and we would go and bring him meals and take him out for a ride or whatever we needed to do, which she really appreciates now. But it was hard for us because she would get so angry with her mom. And it was like borderline, do we call somebody on her?
She was just really struggling. I think you hit on another great point. I'm going to go on another mini tangent, which is this idea of caregiver readiness. So we use a model often called the trans-theoretical model. Has anyone heard of that? It's actually based on smoking cessation. But sometimes we'll kind of generalize that to the caregiving population, especially caregivers of people living with dementia. So we think about these different stages. We have pre-contemplation, contemplation, preparation, action, maintenance. Did I get 5? What? Who would? Evaluation. Okay, thank you. But we think about that, if we kind of overlay that onto caregiving, somebody who's in a pre-contemplation stage, they're really not yet acknowledging or aware of what dementia really is. They're not ready to change their behavior, ready to fully understand what it is that they're addressing or dealing with. Contemplation, someone starts to recognize, okay, yeah, I realize there are some challenges here. I'm going to have to make some changes. Once we get to preparation, that's when someone's like, okay, there's an issue. I'm going to I need to start preparing to change my behavior. They start asking questions. And then once we usually lump kind of action and maintenance together in caregiving, but that's usually somebody who's like ready to go. These are the caregivers I work with where I walk into the home and they're saying like, okay, Rachel, I identified that my family member is, I had a caregiver one time who would say like, my resident is picking at his depends, and it's becoming a huge issue, so I decided I still wanted him to feel like he had something comfortable on, so we just started putting regular underwear over his depends, and it reduced his picking, and then I gave him a fidget item. Like, that is an action, high readiness caregiver, right? Identifying an issue, changing behavior. Somebody who's pre-contemplation or contemplation, they're not yet ready to make that behavior change. So these are our caregivers who are saying things like, my mom's just stubborn, she's always been this way, she's doing this to spite me. The best thing we can do for caregivers at that stage is just meeting them where they're at with education. So if we try to, and we can also demonstrate strategies for them. So we can't really expect them to start implementing too many strategies because they're just not there yet. But if we can meet them where they're at with education and start to really set by example, show by example how these strategies can help, we can try to inch them along that readiness spectrum. But yeah, I really appreciate you sharing that because that's an important piece of the puzzle too, right? As professionals, these strategies are great, but if we're working with a caregiver with low readiness and they're having difficulty implementing, why is that? Where's their readiness? And how do we meet them where they're at?
And even small things. I mean, they went down and they were going to get rid of everything that their parents had in their apartment. I said, now listen. I said, some of those things have meaning. Well, she wants to keep the table. It's a ratty old table. I said, ask her why she wants to keep it. And so it turned out that that was the table that somebody had gifted them with when they first got married 60 some odd years before.
Absolutely.
And I said, so it's okay if it's ratty, it's comfortable and it has meaning to them. And I said,
Absolutely.
she goes, but the cushions are all gone and they're hardwood. And I said, well, we'll figure
Doesn't matter, right?
So-
Exactly.
So I ended
Thank
up
you.
reupholstering their chairs for them.
Oh, lovely. But
And they
again,
love
I
it,
appreciate
because
that.
it was still the table.
Yep, still the table, comfortable, familiar. Again, when we're talking about environment too, making sure we have that familiar environment, that it's routine. Thank you. Those are fantastic points. I appreciate you. Couple other points about communicating effectively. I know I mentioned this concept of redirection a few times, but especially if somebody starts to exhibit some signs of agitation, that's a time where we definitely want to, do some redirection. Using words of encouragement. So again, this is where, to your point, we want to be thoughtful about how we're using words of encouragement. We don't want to cheer someone on in a patronizing way. Usually my words of encouragement, my go-to is just thank you. Thank you so much for your help. This was really thoughtful. I really appreciate you. Those types of things, because they're not necessarily childish in the way that we're saying them. Even if someone is just able to, lift their foot up while I'm helping to put their sock on or their pants on. Thank you so much for your help, right? It's not like they have to be participating in this really tremendous magnitude, just anything that they're able to contribute. And speaking slowly, that's a challenge for me, but speaking slowly and allowing enough time for our client to respond. I oftentimes will tell caregivers, you see me, I talk fast, I get it wrong. I'll be interacting with someone with dementia, I clearly spoke too fast, they didn't process. I will stop, I'll wait, sometimes I'll walk away, walk into a different room, I'll come back, and I'll try again. So there's no reason that we can't just try these strategies over again. We give ourselves enough time. We also want to look directly at the person when we're talking to them. So we don't want to be, in the refrigerator grabbing something and saying like, hey, hun, did you get a shower yet? That's going to be too complex. We really want to make sure we're looking directly at the person with dementia when we're talking to them. Using cues. Again, I know this is inherent to OTs, so sorry, Abby and Tamsin. But for anyone else who might not always think about the types and ways of using cues, I think it can be helpful to break it down. So there are visual cues, demonstration or modeling, verbal cues are what we say, and tactile cues are like gentle touch cues, essentially. So a visual cue, that would be some of the examples in the pictures. So labeling a drawer with a picture and the word sock. We could also potentially put a stop sign on the door. There are a lot of other ways, sometimes more effective ways at reducing wandering. We can get into that later if you want to, but those would be examples of visual cues. Again, demonstration, that would be, I start eating with the person at the table to help encourage that they eat with me. A verbal cue is when I would actually say something like brush your teeth. Honestly, verbal cues I use last. I'll try to do anything else first before I start to use verbal cues. Again, that's because I can be really wordy and chatty, and so that's not usually my best choice. Sometimes I'll say to caregivers, let's see if we can facilitate engagement in this activity. Let's see if we can get the person to do this activity without using any words. And then that way, if we choose to use words, we're really thoughtful about which words we're choosing to use. And again, tactile cues, that could just be a gentle touch cue. So I had a client one time who she would, sit with the oatmeal in front of her and hold the spoon, but she wasn't necessarily bringing spoon to mouth. Just a gentle kind of tap, tap on her hand was enough to get her started. So sometimes tactile cues can work. And then some general considerations. Again, I think we've highlighted this. Procedural memory, anytime we can tap into that muscle memory is really helpful. So really enhancing routine, not rushing. We use this little phrase called relax the rules. Just this idea of, again, it's not about the end product, it's about the process. Enhancing comfort throughout. I also really like activity boxes. So if we can, especially for caregivers who get overwhelmed easily and they're like, well, I tried this and my family member didn't like it or was resistant, if we can spend some time in advance thinking about what's their cognitive level, here are a few activities that match that, let's put them all together in a basket or a bucket. That way, when we go to engage them, if they're resistant to one, we can easily pull out another. Or if somebody's covering for us or providing respite, we could easily say like, hey, here's an activity bin, try one of the activities in the box. Okay. Some barriers to engagement. So a few things to consider. Lack of time, lack of support, lack of assistance, and also resistance. So I'm going to go through resistance very briefly, and then we're going to apply all of this and share as a group. If you guys want me to talk in more detail about resistance, I can certainly do that. But I'm just going to say first, we're going to identify the why. So I went on this tangent a little bit earlier related to the driving and the sense of loss of control. But the first thing we want to figure out is why is the person being resistant or experiencing resistance? So some common ones, I mentioned loss of sense of control earlier, but other things that come up are they're uncomfortable. They're in pain, the temperature in the room isn't a good fit, they're feeling overstimulated or overwhelmed by what's going on in the environment, they're fatigued, they're really tired, they've had a long day. The time of day could be a factor. Our communication style as a caregiver, did we ask them a yes or no question? If so, 9 times out of 10, the answer is going to be no. So thinking about a different way of framing the activity. Different environmental triggers, how many people are in the room, all of these things could create resistance. Once we identify what the specific triggers are for that particular client, patient, or family member, then we want to modify that. So again, I'm going back to Tamison's great example earlier from the driving. We identified the sense of loss of control being an issue, so Tamison's strategy is directly related to providing control back to that person living with dementia. And again, that's also where doing something like asking for help can be really a good way of framing something because we're reducing that sense of loss of control. We're not telling someone what to do. We're not telling them how to do an activity or what to do. Instead, we're saying, I could really use your help with this. That puts them back feeling a sense of control. And then any underlying concerns, so also are they feeling safe? Are they comfortable? Have we reduced pain? Are they sitting in a comfortable position? All of those things should be considered. And then again, I mentioned this, sometimes I just walk away for a few minutes, reset, and then come back and try again. Okay, enough of me talking. I'm gonna let you guys actually apply these. So you have a couple sheets in front of you. One is a little worksheet related to some of the things we've talked about. So selecting an appropriate activity. So I want you to think about a client that you've had, either currently or in the past with dementia, a family member, anyone with dementia you want to think about. I want you to consider what their cognitive level might be, and I can go back to that slide if that's helpful. I also want you to think about what activity you want to choose and why. So is it meaningful and purposeful for that particular person? And then think about some strategies to adapt the task, simplify the task, modify the environment, and adapt to communication style. And then we'll share them as a group so we can all build our toolbox. Does that sound okay? Okay. And you can work as a group. Chat amongst yourselves. Do you want me to go back to the cognitive level slide? That'd be helpful. Okay. I might just have to hit back a bunch. Not sure. Here we go. So this is the part that I didn't comment too much on, but you can see at a level 4, attention span is a maximum at that stage of an hour, and at a level 3, the maximum is 30 minutes. So something to consider as well. And while you guys are working, I'll pass around some of these activities.
Yeah. We're at 50 pieces now. Oh my gosh. Yeah. That's a good himself.
Yeah, I'm passing around a few activities. So I had mentioned that the HODIA activity. So again, two Vermont women started this company called HODIA. I think it's really quite a unique activity. You know, it's just really simple. They actually started this because they said so often their family and friends were saying, I don't know how to engage mom when I go to visit her, engage dad when I go to visit him. Especially because I think he was having a lot of aphasia, difficulty communicating. So they came up with this card game without rules, which I think is lovely. Also passing around a Mind Start puzzle. And then also there's a Mind Start word search. So there's like different levels. Some of them are more complex, and then you get to the end and it's more simple. And then I think the last one I started passing around was a newspaper for people living with dementia called the Resense Register. I actually really love it. It's pretty new, but I love it. So it's got, you know, large print. The stories are all pretty benign, so it's nothing upsetting. The pictures are big. It's got a really big, I think, like word search or crossword in it. Yeah, I thought that was fun.
We don't have to hand this.
Oh no, you don't have to. You'll have to hand in the, if you came for continuing education, you'll have to hand in the evaluation of the course when you head out, and you'll get your certificate, but you don't have to hand in the other act. It's free. Yeah, go ahead, Abby. Okay, yes.
So like,
Mm.
not
Yes.
but not like
Yes. Yeah, yeah. Great question. Truthfully, oftentimes what I've done is I get like the old school like clip art and I blow it up on a Word doc and print it out. But I think that it would be nice if we had more options for that, and like actually on like not just printer paper, but like coloring book paper. I'm trying to think. I would have to double check, but Dabblesack, I do think has coloring books, but they might be mostly adult coloring books, like most of the fine motor. But I can double check that. Yeah, Dabblesack should be on the resource page. Yeah, good question, Abby. I might have to look into that though.
trying to transition all coloring books in-house are like, and all those with the itty tiny
Yeah.
little spaces, that's just way.
It's too much. Yeah. That, and they do make some paint by numbers, but some of them are really itty bitty tiny, but some of them are more reasonable. I think I found some even on like Etsy. Again, they're a little bit pricier, but oh, thank you. You know what? You can actually hold on to it and hand it in. Thank you. Appreciate it. Yeah, and I should say too, even if you're not here for continuing education, it would still be helpful to fill out the course evaluation. I'm happy to have any sort of feedback. All right, while you guys are still working, I'm thinking we can have some people start to share. I'm gonna use this microphone for that. So is anybody willing to share what they came up with? Thank you.
Do I have to press a button or anything?
I don't think so.
Okay. Okay.
Yeah, whatever you want to share about it, we'd be happy to hear from you.
So,
Is that working?
can anyone hear me?
Yeah.
Okay. My name's Kaya. I'm a life enrichment coordinator at a memory care community, and I've actually used this recently, and I'm really excited about it. So one of the residents has a family member who works as a florist, and the family member told me that they had flowers that they just throw out. So I was like, okay, we would love to have those here and do floral arrangements. So we had a whole bunch of flowers dropped off. And we have one resident in particular, her level, I believe, is about 5. I chose this activity, floral arrangements, because she was the biggest green thumb. Like, she'll go around and water plants a little bit too much sometimes, or, so I set up vases with water in them. I cleared the table. I put the flowers on the table. When I asked her about helping me, so I said, we just received a huge order of flowers. Could you help me vase them? I brought them over. I brought like one of the big pails over just to have her look at them and be like, oh. So I was like, could you help me out? So yeah, I cleared the table, any background noise, placed the flowers out. The only safety considerations were like the scissors, and because some of the stems were very, very strong, and but we decided we could just rip some of them. But yeah, that was one of them. Yeah, she was very busy. She was very busy with it.
That's incredible. Thank you so much, Kaya. Fantastic example of, again, being client-centered, so thinking about what's important to her, having something where process over product, because it doesn't matter, there's not one right way to arrange flowers, right? Beautiful. Love that example. Thank you so much for sharing that. Who else wants to share? Thank you.
Hi, so I'm Kate. My story, I don't want to say it's sad, but so the reason that I'm involved is I work for Adult Protective Services, and this case wasn't mine, but the initial issue was there was a caregiver. We call them victims or AVs. The AV was hard of hearing, but also I think she was around a level 3. So there was some caregiver education that kind of went into this case. But again, this victim was a homemaker her whole life, was very big into making her bed every morning, which often led to caregiver frustration because she would get about halfway through it and then would be done. So there was stripping the bed, and it was a big chore, and she wanted to help with laundry, but wasn't helping really with laundry. So what my colleague had done was we worked on, educating caregiver, and it was a laundry basket filled with brightly colored socks and washcloths, and that was her chore she would sit down and do with her caregiver. And again, there was no goal. It was just, organize it however you want. And, every morning part of the routine was you can strip your bed and that's fine. And, that was part of, again, the routine of that activity. But a big piece of that was also just the house needed to be a safer environment for this woman. And part of that was a propane stove and cleaning materials and cleaning supplies. So moving all of these items like laundry detergent and bleach, all of these things had to be, and the visual out of sight, out of mind was a big component for this woman. And it almost completely eliminated the caregiver frustration, which was that was one of our better outcomes. So that was really exciting to see. But yeah, that laundry basket with the socks and the washcloths and oftentimes she would sit outside to do it as well, which was lovely for her. So that was that was a good one.
Thank you, Kate. Perfect example. And again, beautiful example of meeting her, what was important to her, and also adapting it to cognitive level too, right? Like simple matching, simple sorting, simple folding, that's going to be more appropriate at that level 3 stage versus something that's more complex. Like some things are just really hard to fold. That's going to be more appropriate for somebody maybe at like a level 4 stage. But things like socks or washcloths, towels, a little bit simpler, perfect. So thank you. Thank you so much. All right, who else wants to share? Anybody from that side of the room? You guys are like, don't put me on the spot. Yeah, thank you. Appreciate it. Thank you. Yeah, that's okay. We're not aiming for.
I definitely don't. Right. I definitely don't need this because I'm very loud, but
Hi, everybody. My name is Brielle. I work for VDH, the Barrie District Office, as a chronic disease public health specialist. Shout out to my background in Rutland Regional Medical Center. I did work with OT for 4 years and physical therapists to provide patient care in this way. So I feel very passionate about this. But I did painting for a patient that was anywhere between a 5 to a high 3 level. I chose this because the patient had a history of loving painting and it sparks joy for them. The strategies to simplify it, I was thinking, would be to include like a smaller table that would fit just the art piece that they're working on. And again, like you said, process over product. Is that what you said? Yeah. Not caring much about how perfect or how pretty the artwork would be. I would simplify the environment by having only the materials for the art, including maybe just a tablecloth and that's it. They could be near a window if that inspires them, or away if that distracts them. The communication strategies to enhance engagement. I don't think I answered that correctly. I said to focus on tactile. Maybe we can simplify painting if they aren't feeling comfortable painting by just literally opening and closing paint tubes. Feeling brushes, textures. Let's see, what's the next one? And then safety considerations. I said maybe we use the circle paint pots, tins, instead of like, you know, those paints where they're really sharp edges that you roll back. Avoiding those, flexible grip paintbrushes, having thicker handles so that the clients aren't worried about holding such thin paintbrushes for easy gripping, and plastic, no glass. Those were the things I thought were good for painting. Yeah. Yeah. Of course.
And you made me think of a couple points. Fantastic example. Thank you, thank you. You also made me think of, I think you said like a range of cognition. Love that you said that, because one thing I didn't mention when I was talking about these levels, this is particularly helpful for people with Alzheimer's disease, vascular dementia. When we start to think about Lewy body dementias, this fluctuates drastically. So for people with Parkinson's dementia, dementia with Lewy bodies, those individuals can fluctuate between functional cognitive levels hour to hour, day to day. So that's important for us to know, because we need to know where someone's functioning, but also it's really important for us to educate caregivers about that, because the way that we're setting up a task, or the type of task that works one day, might be totally different the next day for somebody with a Lewy body dementia. Versus, again, Alzheimer's disease, vascular dementia, typically someone's going to stay at the same level for quite some time. And Brielle, you mentioned something else that made me like, oh yeah, I was going to mention something, and I forgot. Yeah, thank you.
I wish I knew what it was.
Yeah, I know. That's okay. It'll come back to me eventually, but I appreciate everything you shared. The safety considerations. I was thinking about something that I haven't talked much about, but people with dementia who can sometimes put things in their mouth too, right? Again, especially when we start to get into like a lower level 3 or level 2, putting things in their mouth can be more common. So we want to be thoughtful about the items that we're using. So I might not do something like sorting coins for somebody who's prone to put things in their mouth. If I'm doing something with paint, I'm going to make sure maybe it's a paint that I might use for kids that's safe in case it were to get in their mouth. So we want to make sure we're considering that when we're identifying the types of items we're using as well. How prone is someone to putting an item in their mouth? And also thank you for considering the physical abilities too, like a built up, call it built up, but a thicker paintbrush handle. So sometimes we can use styrofoam. There's lots of like easy things we can get to wrap and make those handles thicker. So we can do that for utensils, paintbrushes, all sorts of things. So thank you. Great examples. Anybody else want to share? Yeah, time-wise. I think we have just a couple minutes left, so I think I'm just going to kind of summarize here with some resources. You do have resources on the back of your page, the page you've been working on. So I'm just going to kind of tell you a little bit more about some of them, and then if there's any lingering questions. So again, I'm just going to keep shouting out Hodier because I'm a big fan of any Vermont-based local small businesses, but there are some lovely people. I think those stacks of cards are going around. MindStart, also going to shout out any OT-based business. So it's a OT Monica who started MindStart. Not only do they make puzzles, but again, they make those word searches. I think they're going around somewhere. They also make lots of different products. But this one's called Look and Lace. Some of these are more childish, I will say, but for some people, they're a good fit. This is more appropriate for somebody, again, at that kind of lower 3 end, repetitive manual action. Sometimes I'll actually lace these all up and then say to someone, you know, I really need to get the lace out. Will you help me? Again, just kind of framing it a little differently so we can pass those around. I forget, I want to say got these at SNS Worldwide, but I could be wrong. I need to double check. This is called Aqua Paint. These are one of my favorites. These are just, they look like just white piece of paper, but when you wet them, they turn into some beautiful pictures. So this is fun because you can use it with a paintbrush, a wet cloth, a wet sponge, really anything that someone can hold, and you can do it together. Once they dry, they turn white again, so you can reuse them a ton of times. I would pass them around, but there's not much to look at. Then we have Arts Connect. Again, I mentioned this nonprofit that I love, Arts Philly. So again, some of the virtual arts programming. SNS Worldwide has lots of different products, but you can search specifically based on senior activities. So that gives you more products that are more relevant to people living with dementia. They're also very quick to add you to their mailing list. Again, SNS catalogs all the time. But I actually think that that's an activity in and of itself. So I'll bring my SNS catalog to some of my clients' homes and be like, let's flip through this and find some activities that sound fun. Joy for All Pets. These are robotic pets. They're very lifelike, especially the cats. They're a little more expensive, but for anybody who's a big pet lover, but maybe having a pet isn't realistic, the robotic cat it like purrs and moves around, all sorts of stuff. And I had a client one time who knew it was a robot. I mean, she would say like, this is my robotic pet cat, but she still loved it. So yeah, that could be a great fit for some individuals. Dabble Sack, also partially OT owned. So they can do like baskets specifically for someone with dementia, but they also have individual products. They didn't create, but they sell a game called Ouisi, Ouisi. It's very similar to the Hodier card game. Lots of different fun pictures, no specific rules. They also make what they call dablets. So this is a great sensory-based activity. This is one of my clients who was doing a lot of fidgeting. She was also putting a lot of tissues and trash in the cushions of her chair, and her husband was like, this is driving me nuts. So we gave her something to just keep her hands busy. So this has sequins on one side, just a really nice, soothing, relaxing tactile sensory activity. So it's a dablet from Dabble Sack. Connectivities, also OT owned. They have a little bit more of a rehab focus than a habilitative focus, but for somebody who's trying to work on fine motor coordination or something, that might be a consideration. Also, the Alzheimer's store has some great fun products. They also sell things like the Joy for All Pets. The Alzheimer's Association has a list of 101 activities to do with someone with dementia. Again, I think that's a fantastic start for caregivers who are like, I have no idea what to do. Usually the questions I start with have to do with, what did this person do for work? What did they like to do for fun? What brought them joy or meaning? And then if all else fails, definitely having a list of 101 activities. Usually we can come up with at least 3 to 5 that sound doable or reasonable. So those are just some places to start. We have 4 minutes left. Does anyone have any questions? Anything you all want to share?
You had said earlier that the Allen Cognitive Scale
Yeah.
would be different if someone had Lewy body dementia. What if someone had a TBI first and then was diagnosed with dementia?
That's a really great question. So this scale of the Allen's Cognitive Disabilities Model can still be applied to people with other types of cognitive impairment, so it can be relevant for somebody with a traumatic brain injury. I think it still would be helpful. I'm trying to think of my clients who had a TBI and dementia. It would still be helpful to do the formal assessment to get an idea of where someone's functioning. There may be some other considerations for someone who has also had a TBI, for example, possibly some, again, like impulsivity or other things we have to consider, but I still think the model should hopefully be relevant and helpful. Yeah, of course, great question. Any other questions? Yeah, Rhonda.
I'm sorry, may have missed this.
No, you're okay.
What about someone with dementia who suffers a fall, including hit to the head,
Yeah.
which may or may not be a TBI? Any considerations there in terms of OTPT?
Yeah, great question. So if somebody had dementia and then has a fall, what would be some additional considerations for OT and PT? So after they've been evaluated by a physician to make sure there's no additional head trauma, anything else that needs to be considered, if they've been brought back to the home and kind of cleared, there are usually a few things we consider. One, it's possible that we'll notice some advanced cognitive decline. So depending on the severity, if they hit their head during a fall, we might notice that, they went from a level 4 to a level 3, for example, in terms of their functional cognitive level. So one, we're going to have to think about, do we need to make additional adaptations to their day-to-day activities to meet their kind of new functional cognitive level? But another thing that we would strongly consider as OTs and PTs if that happened, and please, Abby and Tamsin, I'm just going to call you Tabby. Please chime in if there's anything you want to add here. But I think a big consideration would be then fall prevention. How do we make modifications to the environment to reduce the chance that that fall is going to happen again? So we take a lot of the same approach to falls as we do to dementia-related behavior, which is, why did this fall happen? So what was going on within the person with dementia? Is it fatigue, anxiety? Are they pacing? Do they have limited endurance, limited strength, medication side effects, sundowning, right, which I go on a whole tangent about that. Yeah, environment being a huge, huge factor. What's the lighting? Are there trip hazards? Are there thresholds? What's their shoe situation like? Did they, they have like treads on their sneakers and it gets caught on the carpet and that catches them. We're also thinking about the caregivers, the caregiver unintentionally rushing someone. So we're thinking about these 3 pockets again of what's happening in the person, what's happening in the environment, what is the caregiver doing or saying, and then making those modifications. Tamsin or Abby, any other? Yeah. Those would be the main things we're considering from an OT and PT lens. Yeah, thank you, Rhonda. Great question. Any other? Yeah, go ahead,
I
Tamsin.
was just going to add too, I mean, sort of overarching, something I encounter so much is that fixed thinking of the caregiver. So maybe their caregiver readiness has improved, but they may then say, oh, I've already tried that, it doesn't work. And so knowing that you can come back to it again and try again in a different setup.
I really appreciate that.
The fact that for normal, like neurotypical people, it takes about 2 weeks to establish a real routine. So if you try it for 48 hours, and you're like, it didn't work. It may not be that you just haven't tried it long enough.
Yes. Absolutely. Thank you both so much for those tips. That's huge. I do think, making sure, again, we're trying things. I usually tell people try it for, unless it's creating negative results, which is very rare. But if we're seeing negative side effects, of course, stop immediately. In the event that it's just not necessarily doing anything, we're not seeing improvement, try it for a minimum of 2 weeks before we write it off. But to Abby's point, 2 weeks is not long enough to establish a new routine. So if we're thinking about routine enhancement, we would need longer than that before we write it off. Yeah. Thank you. Any other last minute questions, comments, thoughts? I also have, if anybody wants to peek through, well, it's more OT based, and you two have all this, but lots of assessments if anybody wants to look at Alan's assessments. But yeah, happy to chat afterwards if you have any additional questions. But thank you all so much for joining this afternoon. I appreciate you being here. Thank you.